Rights-based perspective to mental health would just mean that we start moving away from looking at mental health as an individual-centric problem and start focusing on how there are social determinants to mental health and how people have a right to be well. And not just from a charity perspective of wanting to help someone, but actually enabling them to access the rights that are available to all of us. There are many benefits of using a rights-based perspective. The primary being that people feel more in control of their lives, and an episode of distress or a chronic condition does not stop them from living a life that they wish to lead, which I think is a huge advantage. And it really shifts the narrative from a more medical, traditional understanding that once you have an illness, then your life is kind of preset for you. This rights perspective then brings about that shift to understand that people have control and people can lead the life that they wish to, despite feeling distressed. QualityRights is a framework which is developed by the World Health Organization as a global response to human rights violations that happen in mental health care settings across the world. We implemented the project in a state in India called Gujarat across 6 mental health facilities. And the impact of it could be seen at all levels. So it was a more health system strengthening, which included every stakeholder's voice, which included the mental health care professionals from all sort of disciplines and not just a particular cadre of psychiatrists. But we did include a lot of people who are working in and around the facility. We included people with lived experience because they are the least heard amongst this whole hierarchy of mental health care. One of the most prominent examples is of introducing peer support volunteers. I think this was the first time in India that people with lived experience had a place within the traditional health system framework where they had a voice and they had a role in looking at people's recovery, not just from a medical point of view, but as a recovery-oriented view, which allowed people to get access to services that they needed. I think anyone who would want to start doing it should think of doing it as an entire cycle and not just stopping midway, which is crucial only because I think once you know what the gaps in mental health care are, it's important to provide that support and continue the momentum rather than losing it. It is a process of change, so it needs all the steps to come together. And I think one of the benefits that we had in India was that we started off with an assessment, followed by improvement plans, followed by capacity building, followed by an ecosystem where service users and caregivers could feel supported, and then followed by peer support volunteers working in these facilities, and ending it with also measuring the impact and effectiveness of it. I think peer support has immense value. It is one of those unique interventions that we know work, but somehow we've just never capitalized on it and used it to its fullest potential. It is especially useful where there is a lack of resources, which is most of mental health care. And I think the main benefit of it being that it provides this aspect of support which does not exist within traditional medical models of care. So it broadens this whole understanding of what is recovery and what is well-being, and it connects people at a level that that helps them discover who they wish to be. And we've seen the impact of it within our setting of Gujarat, where we've introduced this for the first time, and it continues to exist. More importantly, the fact that the state government is supporting it financially shows that there is enough value that even the governments can see, and there is enough buy-in. But of course, there remain challenges of changing this traditional healthcare system to adapt to the needs of peer workers, which might need a whole paradigm shift of how mental health care is done. In India, we don't have a community health worker. We have something called a social worker who's supposed to be in these hospital settings, who primarily do engage with service users in terms of understanding where they wish to live, planning for their discharge. But as most things go, the resources are quite scarce, and they don't have enough time to address for all these individualized needs. And there is a whole narrative that is brought in from a more medical perspective. And I think this completely shifts when it's a peer worker. So it is supposed to be someone with lived experience who can understand what another person is feeling, who can relate to their challenges that they're facing, who can also be innovative in how to bring about different solutions that could be possible. And also actually not be limited just for healthcare systems, but also go out into the community and assist people who might be going through a difficult time, and not just in that difficult period of time, but also times when they're well, to plan for their wellness plan and not just a distress period. Mine is definitely Article 19. I think that has the potential to shift the discourse of how mental health is looked at. It is trying to talk about independent living within the community setting, and what is that independent living needs a lot more discourse and discussion and huge implementation challenges that need to be thought through. But I think it's one of the key areas which can shift this pyramid of care, which is more top-heavy, and make it more heavy within the community setting of self-care and informal care. So I think there's huge potential in doing that.